This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Mariana Parks, physical therapist and your host, and today I'm joined by Hans van Helvoirt for a conversation about managing radicular syndrome, MDT and epidural injections in lumbar disc herniation. We discuss how epidural steroid injections affect MDT classification, the potential of combining MDT with epidural steroid injections to prevent or delay surgery, key findings from a randomized controlled trial on the effectiveness and cost effectiveness of this combined approach, when and which patients we should refer for epidural injections, and more. Hans is a physical therapist and international faculty member with the McKenzie Institute. He has taught MDT globally since 1993 and serves on the Institute's Faculty Council and Public Health Committee. Hans consults at Rugpoli, Brabant in the Netherlands and conducts MDT anesthesiology research with VU University Amsterdam. He received the McKenzie Institute's Bronze Lady Award in 2017 for his research contributions. If you find our conversation informative, don't forget to subscribe, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who could benefit from these insights. Thank you for tuning in, and now let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Neck care.
Treating neck impairment? Get objective neck assessments with the Neck Care system. Learn more at neckcare.com.
Hi Hans, welcome to PT Pro Talk. How are you today?
Oh, I'm fine. Thanks for the invitation. I'm looking forward to our conversation.
Yes, we've been waiting for a while now for these papers to come out, and it's like a soap opera of papers being published. So I'm glad to finally have you here.
Yeah, it took a very, very long time, as you know. But
yes.
that's sometimes you go to a certain journal and then it's rejected and you go to the next one. So the randomized control trials was rejected 3 times, I think. So then it takes a long, long time to get it published. But it's there.
Yes, finally, you made it. So let's just start talking a little bit about yourself and your background. So for the ones that don't know you yet.
Oh, all right. So as you said, my name is Hans van Helvoirt, which is a difficult name to say, so I will tell it myself. I'm born and living in the Netherlands, in the south of the Netherlands. It's a very small country, but we're in the south are different from the north. That's what they say. But anyway, so what I've done, I studied physical therapy in Utrecht, and I did my manual therapy schooling in Switzerland with Jeff Maitland, and I was really taught by Jeff Maitland himself in those days because I'm an old physical therapist. That's the reason. And then actually. Jeff Maitland, he said at the end of our examination, he said, yeah, it doesn't stop here. This was just manual therapy, and that's what it is, and it's not more than that. So you really need to keep on studying. And so I asked him, so what would you suggest us? And he said, well, in that time, he said, there are a few things I would suggest, and one of that was McKenzie method. Where he said nicely, because we're very friendly man, he said, I think it's very important to think about self-management, but don't believe his theories. And that theories was the disc model in that time, so which he was not liking anyway. So then I did some other courses before I started my McKenzie training in the Netherlands, ABCD. And then in 92, I went to New Zealand for doing the diploma course in Robin's Clinic in Wellington and in the chronic pain center as well. And I was lucky because I was the last group who really was taught for a part by Robin himself. So I was still lucky with that. And then I came back and I thought, now I can treat everything. But unluckily, in the first week, a few patients, I had no clue what to do. So I was thinking, what do I do next? So I started to think about we are treating human beings, and human beings have a brain, and they have experiences, and they have all sorts of ideas. So that's why I started my Master in Arts and Psychology. So I did that afterwards in Antwerp, in Belgium. And then, so I was working in different places and ended up in manual medicine practice in The Hague, in the Netherlands. And then later on, I was invited to lead the Rug Polycenter in the south of the Netherlands, Tilburg, where I'm still now. And that's a center where actually the McKenzie system is really the center part of the triage of patients. So we really examine everybody with MDT, and all the physical therapists who are working for us are diplomats. And we work together with neurologists, rheumatologists, anesthesiologists. We have MRIs in the practices. We have 6 different centers, but I'm only in the south, which is enjoyable because I can just knock on the door for an anesthetic block if I want that. And actually, I think the physical therapist is more or less saying what we want to have and how we're going to treat this patient together, of course, with all the others, but we are sort of differentiating what we can do conservatively and what patients need further investigation or an injection or whatever. So it's a little bit the other way around than in most clinics where the doctor is saying, we're going to do this and you may do that. We sort of are on a horizontal level dealing with the patients and discussing. And everybody has his view and can really discuss that view as well. So it's open to everybody.
Well, that's so great that you always speak the same language. So how did that happen that everybody's kind of MDT trained is like...
Well, that's a long... I will make it short. It's a long story. Actually, the first... It started with my first paper, which I wrote with Ron Donaldson and Charlie April. And I went to Charlie April's clinic, radiologist, unhappily he's not there anymore, but and he did the injections. He was actually the president of the International Spinal Injection Society, as it was called in that days. And I was in this clinic when Mark Lissert was there as well, doing some intakes for his PhD. And I saw the first time I saw all those injections going in necks and backs. And I thought, wow, what's happening here? And we were discussing that, how we could combine that with MDT. And then I was teaching in the Netherlands on a course. And there was this manual medicine doctor who was a son of 2 anesthesiologists. And I was talking about what I saw in New Orleans, and he was really interested. And he said, "Oh, can you introduce me to that clinic?" And I thought, "Yeah, we'll do that, no problem." So I phoned Charlie. Charlie said, "Yeah, he can come. It's no problem." And then 1 month later, he called me back. This doctor called me back, and he said, "Thank you so much for introducing me." So, "Oh, what do you mean?" So, "I've just been there a month, and I bought my first C-arm, and we're going to start to do this injection. So we should talk together." So that's sort of where everything started.
That was quick.
Yeah, very quick. And then it growed a little bit, and we got another center, and we were discussing, and then the rules in the Netherlands were changing, so we needed an anesthesiologist and a neurologist and blah, blah, blah. It's a long story. But and then we saw, like, okay, if we keep on working on a horizontal level, and what McKenzie is good at is, of course, looking at the people who have a good prognosis with, if you can centralize or directional preference, which was a big amount of patients, then we can sort of rule out already those. And so we gave sort of, we build up an algorithm centrally built around the MDT material. And actually all the specialist doctors who came working for us, they were all trained in MDT as well. So they had to do that. It's just no question. You have to do an A and a B course, which most of the people really liked. Doctors really liked. So we got them on our courses. And in that, I think that's one of the most important things is that's why we can talk the same language.
Yeah. Mm-hmm. They have the basic level of knowledge than what you're doing.
Yeah, they don't need to know how you do overpressure or how you force progress, or they need to know what we talk about, and they need to know the basic principles. So an A and a B course is okay. But we have two anesthesiologists who are credentialed therapists as well. They never treat a patient with MDT, but at least they have a good knowledge on
That's
what
awesome.
we're doing. Yeah, it's really fun.
Yeah. So then what happened after that? So you have the center, you established that, and then like what prompted your interest in like start researching about it? How did you get involved with that area?
So I just mentioned my first paper, which was just a lucky shot because I did a physician's course with Ron Donaldson and Charlie April. And on that course, there was this beautiful lady, but absolutely shifted for 4 months already with a radicular syndrome. And when she came in, she couldn't walk. She was crying, and she was scheduled for surgery the next week. And so they said, "Can you look at her to see if you can change something?" And I thought, this is not nice. It was in the hospital where we were doing that course. So I was already to the group. I was already saying, "Yeah, this is 4 months there. It's shifted and radicular down the leg, neurological symptoms. So I think if I'm gonna shift correct her, you're not gonna see centralization where Ron Donaldson was talking about just before, but you're gonna see the opposite, peripheralization." So I shift corrected her, and she peripheralized like hell. And then I asked her just to lie down, and she couldn't lie on her stomach flat, so I had to put her into the flex position, and she was just in that same hard shift in that flex position in prone lines. So I started to shift correct her, and what I never saw before, at least not that quickly, she was saying, wow, my leg pain is going. And I said, "Oh, really?" So I was so surprised that was happening because it went so quick. And then, so she said, "Where's your pain now?" "Oh, it's only a little bit in my buttock, but I have this awful back pain now." So, "Oh, yeah, that's all okay," and blah, blah, blah. So I started to do extensions and like in 15 reps. She was absolutely full range of motion. So I stood her up and she was straight and she didn't have leg pain anymore. So she was really happy.
That's crazy.
And Charlie was really impressed by that because he had seen centralization before, but he went up to the podium and he said, "This is so good to see because this is so important to see because I thought I needed to do a transfemoral injection on this patient first before you could do that." And then so we start to discuss when to do that and why, and then so in that same time, that doctor has been in Charlie's place, and so all things came together, and then we started to do injections on patients, and no idea when and what, and well, we did the right ones, but it was not really like how we think now, and we come back on that later, I guess. So and then we felt like, wow, we can do something. It's pretty much okay in the results. So then we started just to collect data, and from there, the second paper came out in 2014, which a lot of people know, I guess, from your listeners, where there were surgery patients, at least 3 months complaints. They had neurology, they had that therapy, which was like field conservative therapy, as they call it. But often like several physical therapy sessions and manual therapy, chiropractic. So really patients who were like waiting at that moment for surgery. But in that time, we had the waiting lists in the Netherlands were like 8 weeks to 12 weeks to get surgery. So the neurosurgeon where I was working with, he said, "I'll go to that practice. Maybe they can do something in between that you don't have that much pain. And maybe if you don't have pain anymore, you don't need surgery. So so collecting those data, we saw that we prevented 78% of the people for surgery. And that came to the eye of some professors, van Tulder and Osterlo in the Amsterdam University. And they say, wow, these are impressive figures. So we should go for a grant, for an innovative grant, to do a randomized controlled trial on that. And that took a long time to get it done. But here we are. We are there.
A long time to get done, a long time to get published.
Yeah. I think we started to collect data in 2018 or 19. 2018, I think. So it's now 25. Yeah, and it's just out.
Yes.
Yeah.
No, that's awesome. And then, so do you want to give us like a brief overview of the 2014 paper and the paper that was just published, and what is similar, what's different, what are your goals and purpose with both papers?
Yeah, so the 2014 paper was called, as they call it, prospective cohort, where you just have this group of patients, you examine them, and I examined the patients and together with two others, and only when they were peripheralizers or non-centralizers, it's always a tricky term, I think, we were saying, okay, those patients we really want to follow. Which was stupid because one third of the patients who were on the waiting list were still centralizing. But I kicked them out because it was my first research really project, and I wanted to have it as clear cut as possible. Mm-hmm. So I only followed the people who got injections, and then what we did was just give an injection and then see the patients back in 2 weeks as an MDT therapist, see if they needed another one. So you can read the details. That's a little bit too much now. And then after the second injection, I would reclassify those patients. And what we saw was that 50% of the patients, almost like 49, I think, from my head, they were centralizers. So before the injections, they were peripheralizers. And then by the injections, they changed mostly a lot of leg pain, and they kept most of the patients kept some back and buttock pain, which we then nicely could centralize. So my simple thinking was we took away a little bit of that inflammation, and that gives us space to move again. Because if it's inflamed, it's swollen, you can't move, it's only peripheralizing. Now the swelling is gone, the inflammation is a little bit gone, and now we can start to do our mechanical stuff. So that was the biggest group, actually. And then we had a group of, from my head, 16% or so who were absolutely better. They already had no problems anymore. So they had no pain anymore. So the 2 injections were enough to take all the inflammation away, or nearly all the inflammation away. And they didn't have any mechanical problem anymore. So that's what I thought were the really chemical inflamed radicular syndromes. All right. And then we had another group, another 15 or something %, who were still peripheralizing their pain if we start to move them, but they had so much less pain that the neurosurgeon was not interested anymore to do surgery. So I felt a little bit weird on that group. And that group, we just gave advice to start slowly, load a little bit more by the week, but really respect leg pain. And maybe we come back on that, what that really means, because I think that's an important one. And then, so 22% of those patients were still really bad. They had 2 injections and they peripheralized like hell and high levels of pain. So they were then having surgery. Right. Mm-hmm. Mm-hmm. So then that was actually, because it was written down pretty well and with all the subgroups, so that was the protocol for the combined treatment in the later on randomized controlled trial. Because if you do a prospective cohort, there is no control group. So you don't know if you leave these people alone or if you do surgery, they do better or not. So that's when you start to compare. All right. Mm-hmm. So we compared in the randomized controlled trial, actually we compared combined treatment versus waiting list for surgery. So we were looking at if we could make a difference with that combined treatment, and our primary outcome measurement was how many people do need surgery or not. And then we looked into the people on the waiting list. They had some medication, pills from the GP, maybe even some physical therapy, but they were on the waiting list for surgery. And the other ones, they had combined treatment, and we were comparing how many people were having surgery on one side, on the combined treatment side versus the waiting list side. And again, it was like we saved 68% of the patients from surgery,
which is a big number.
Which is still a big number. And then I think the most thorough part of the randomized control trial was really very specifically looking at the cost effectiveness, which is way too difficult for me to follow. Because they have all sorts of different analysis. But what I can say about that is that if you look only at healthcare costs, it's an amazing difference between combined treatment versus surgery. So it was like a 98% chance that that would be very cost effective with big differences in costs. For societal cost, where you look at everything like what does the treatment cost, but also what are your sickness days, what does the other treatment cost, how much work do you lose, etc. Then that was moderately cost effective, which is lower. But the biggest problem was that we didn't reach our power, which we had calculated before, because halfway the study, all in a sudden, we didn't get any patients anymore. And you never can prove that, but I think it was really the bias of the neurosurgeons, because they didn't see patients back or not enough. So all of a sudden they start to realize this is going to cost us.
Yeah.
The thing which is called money, I think. That's my simple analysis. And I never can prove that. But it's really strange because we had 70 patients in a row very quickly, or pretty much like nicely going, and then all of a sudden it was gone. Where we had 8 hospitals who were delivering patients. The Netherlands is the number 2 in the world of doing surgeries per 100,000 people on back pain or on radicular syndrome. Do you know which country is the first?
US?
I think so. No, it's true. The US is first, we are second. And the Danes are third, by the way, for the countries which are counting them. So it was really strange that we didn't get. And if you then, so we got a grant from the government, and if you then for a certain amount of time, I think half year or a year, you don't include any patients anymore, they're going to stop the grant. So we had to stop the study, and then you have to publish the data which you have, which was half of the data, which we thought we were needing, but still then, and I think you could see that as a limitation of the study. On the other side, it was still very much significant what we did. So, and although we didn't have enough patients, the cost effectiveness was significant. The health societal costs were significant, and the reduction of surgery were significant. So, still then, it's so I think the power calculation was a little bit overdone. But it's a nice how do you say that, thing which the neurosurgeons can say. They now say it was a nice pilot study, but it should be redone again, of course.
So like when you said that you lost patients but not to surgery necessarily?
No,
because...
no.
Okay.
Yeah. No, so some patients, they just come, as in your clinic, I guess, they just don't come back, and you try to find them back, and they don't answer, It's always that's always a big thing. But to cover that, they did a very impressive. How do you call that again? So they did all sorts of statistical analysis to impute data, which was done in a very thorough way. So in that sense, I think the things which are written down are pretty much what it is. Yeah. Mm-hmm. Mm-hmm. Yeah. And then at the end, we had so another important thing is that we didn't have a difference in outcomes between the combined treatment and the surgery. So it doesn't matter if you do surgery or combined treatment, you have the same sort of outcome. But looking at the outcomes, they were way less good than in the 2014 study. But also, if you look at the surgery outcomes, they were way less good than other studies which are done on herniated disc surgery in the Netherlands as well. So in that sense, they were really, my feeling was they were really an awful, not awful, but were really difficult patients. Also seen in, like in the 2014 study, as although patients were on the waiting list for surgery and they had treatment and etc., we still had 1/3 which were centralizing.
Yeah, that's what I was interesting, because you said that you just studied the 2/3 that were not centralizers, right, in the first study. So like you probably would save a lot more people from surgery if you think about the first group that you excluded, right?
Yeah. That was my mistake. So later on in the second paper in 2016, I phoned everybody. There were like 41 patients. I phoned 3 years later, and then from that 41, I could find 39. So I couldn't find 2. And from that 39, there was only one patient, a centralizer, who had surgery 2 years later. So if all those patients were in the study, I calculated that, then we had 87% of reduction of surgery. Yeah. But in this randomized control trial, the patients were way more difficult. I only had one centralizer in all the clinics, so it was really a different population. That's what I feel. Yeah.
Yeah. And you think it's just the was random that happened? The patients were just, maybe they've been to other treatments, they had pain for longer. Like, do you know why the population was so different?
That's difficult to say, but the in the paper we discussed that a little bit. So one part could be that in the Netherlands there is a big reduction of surgeries on herniated discs since the 2014 paper. So they wait longer, they don't do it that quickly anymore. So maybe that's why my first group of patients in 2013 were lighter. Another thing is that I really wanted the patients to be seen by the neurosurgeon before they got randomized. And then the bias of the patient is already, I have had therapy already. I had exercises, manual therapy, blah, blah, blah. And now I really want my surgery. So their patients are, at that moment, they really like to get a solution for their problem. And neurosurgeons want to do surgery as well. So I spoke, as an example, I spoke to one surgeon who was in the research group as well. And I asked her, why is that? Why don't we get any patients anymore? And she really said, like, in those days, we see so many patients with stenosis. I'm always do surgery on all patients. So once in a while, if I get this nice and fresh herniated disc, I just want to do surgery. And I don't think about sending it in to this trial. So I said to her, so is that a little bit of bias here? I said, yeah, I wouldn't call it that way. I said, but I can't call it differently.
Yeah. Yeah.
So,
I guess that's the same in each country.
That's just an example, so you can't say about everybody that. I found that very, very strange. I've seen some very strange things. Yeah. But still then, it's a nice outcome, I think.
And we are saying that on both groups, the intervention and the control group, the results are not great on both groups, right?
Yeah, much less at least. They are still okay, but they are much less than the 2014 paper. And also from other papers like 𝐤𝐤𝐿 Pearl, who did a study in 2007, which is a well-known study on surgery, in early surgery on herniated discs. And that was early surgery. Those patients we had now were chronic. So often they were at least more than 3 months. Otherwise, you can't do this trial. You wouldn't get a grant for it. But most of I think it was like average, they had 15 months of radicular pain. And also that makes, of course, that other issues are you have to deal with, because it's long time. So you get more interference with psychosocial issues. We do know from research that after 9 months, the surgery is not working that good as well. So that's the other side of the story. So that they didn't get that good results as well. It's more difficult. You get more neuropathic interference, etc.
Yeah. No, it makes sense. And I was reading some part of the paper that you're talking about the surgery, that the intervention was more effective and more costly compared to control. Is in one of the things that it was assessed, the 𝐼𝐸. I don't know exactly what means of.
Yeah, don't ask those questions, because I'm sounding very stupid on that.
But the surgery, it wasn't more effective and more costly. It was about the same, the effectiveness.
That's such a difficult analysis. I can't follow it. But the most important one, I think, for policymakers is if you have to pay for treatment of radicular syndrome, combined treatment is a very good option to do, because you have the same results as surgery, and you have way less, 98% chance that it's that you really have to pay much less than surgery. So I couldn't follow that 𝐼𝐸 thing as well.
I just separated here to ask you, but the main message is like they're both with not great outcomes, but one a lot less expensive than the other one. And even that you lost people through the way, you're still able to know that they haven't done surgery, so you're still able to help people. And then with those that you did the combined intervention, you tried MDT first and then the injection. How was the process?
No, the process is the same as I discussed on the 2014 paper. So I would do an intake, or another diplomat would do an intake. Or actually, they were seen first by a neurologist who does the medical intake. That's how we call it. And then we are searching if we can find centralization or not. And then if we couldn't find it, another difference with my first study, then I got 2 visits to find that out. But now, for ethical reasons, because people came from everywhere, the Medical Ethical Commission said that we only could do 1 examination. And as you know, sometimes you get this like decrease no better or an increase no worse response, where you position your patient for a few days and then it starts to centralize. So we didn't have that time. So maybe there were more centralizers in the whole pilot, in the whole study, than the one we really found on day 1, because we only had 1 visit to conclude that. And then they got an injection, mostly 2. And then after 2 injections, we would reassess again and see how the groups were, how they were subclassified as well again. And that's a secondary analysis we still need to do. So what I know is that we saw way less centralizers. So it's not 50% anymore after the 2 injections. It's more about 30% from my head. And then way more peripheralizers, which had much less pain, but they still didn't centralize. So they really need to load slowly with respect to leg pain. Yeah.
Mm-hmm. And then on those, I remember you had like 4 subgroups, right, from those people. And then just the last one, that was the one that it was not improving at all, you would refer that back to the surgeon. And the other 3 groups, you would just manage with the exercise, MDT, and the injection.
So if they were centralized, they and even also with this pretty chronic group of patients, we didn't use a lot of. I think it was a average 3.4 visits, which is nothing for MDT. So for the centralizers, mostly there were like 4 or 5 visits. For the people who are really pain-free, what I called the resolved group, they only got one visit or maybe 2 to explain and I used McKenzie principles, or we used McKenzie principles to advise, to explain them what they could feel, not feel, balancing out a little bit more flexion and extension if they didn't do that before, etc. So advice based on the MDT principles, and then on the people who had way less pain, so they didn't want surgery anymore, or so we wouldn't send them off for that. People with less pain but still peripheralizing pain or not non-centralizing pain, they got just advice to start moving, whatever they like to do. Is it swimming, walking, biking? In the Netherlands, everybody bikes, so that's easy. Most people do like biking. And then very specifically explaining about respect leg pain. So what does it mean? And I think, and that's what it means is just that we don't want to have an after response after you load your spine in biking or in walking or in whatever. They could go to the gym if they want to do that, and they could get a little bit more leg pain, but it shouldn't stay longer than 20 minutes after going to the gym or after the bike ride. Okay. And if it would stay longer, we really advise them not to stop moving, but do half of the load. So, and that's the experience after we were counting how many radicular syndromes I had seen. And I think it's above 18,000 at the moment, something like that. So with all those patients in my head, what I found out is that people really like to know very precise advice. And that's what I would like to say. It's just explain precisely. So I will always say so what do you want? I want to go for a bike ride. How long would you like to ride? Oh, an hour or so. Okay, that's fine. So you go for an hour. Maybe at the end of the hour, you're going to feel that your leg pain starts to hurt a bit more. Don't worry. That's no problem. But as you sit down or lie down afterwards, your leg pain should switch off to the basic pain from before your bike ride. So let's say it was 2 out of 10. It went up to 5 out of 10. 20 minutes later, it should be 2 out of 10 again. Mm-hmm. If not, if it stays longer, like an hour or 2 hours, or maybe the whole day, or even the next day, or you have a very, very bad sleep, then don't stop biking, but go for half of the bike. So you go half an hour. So you feel that's always very precise. So like half an hour. You start with 2 out of 10. If you do half an hour and there is nothing happening, you're going to sit down and then you see what happens. If the pain stays the same, if it's not hurting afterwards more than 2 out of 10, you're fine. So half an hour is not too much. So you do that a few times, and then you start to increase your load. You start to increase the time or the distance or whatever. And people really, really like that. They often say that it's so helpful to know exactly what I may do or not do. Most people are really scared for radicular syndrome pain. I don't know if you have had yourself, but I had it in my neck, and I can tell you it's not nice. So yeah, it's nice to have some guidance, I think. Yeah.
And I think people feel empowered because they know what to do and how to deal with those symptoms when they show up, so they don't feel so scared, and they know how to track everything. So I think that's very helpful.
Yeah, very helpful. Yeah.
And then on that last group, the non-centralizing with high levels of pain disability, so they would back to the doctor and then not necessarily to have surgery, or most of them would have surgery. Then
the people which we sent it in, they all had surgery. But there were some people, which is interesting because so people had long-standing problems. As I said, an average of 15 months, I think, something like that. And even though they had 15 months of pain, some people still didn't get surgery if they were on the waiting list. So they even then can get better on their own or get much less pain that they say, oh, I don't want to have the surgery. So where we always say, like, in the first 2-3 months, you should have much less pain. That's the normal natural history. The natural history is really, really everywhere. Yeah. So.
And those patients that you mentioned, they were not doing anything, just waiting for the surgery, that they could potentially get better too.
Yes, a good question. One of the things I was not happy with, because it was not followed up very well, I think. We are not really clear on what those patients were doing. Another thing which I find difficult is that so they went to the neurosurgeon, then they got randomized. And some neurosurgeons, they just set a date for surgery, like 2 weeks later. So then I have had myself 2 of those patients say, okay, thank you for being part of the study, blah, blah, blah. And we're going to do an injection in your case. And then in 2 weeks' time, I will reassess you and see if you need another one, and then etc. So explain what we were doing. And those patients just said, no. In 2 weeks' time, I have surgery.
Yeah, it's hard.
Which is manipulated. It's biased. It's
They
so
are ready.
It's
ready logic to have the surgery, so they're not willing to open and willing to try something else.
Yeah. So my now it's out, and for a few months out, I think, well, it's not too bad. Actually, it were pretty good figures, knowing all those things that happened. Where I think it's happening in every randomized control trial. Mm-hmm. Because it's difficult to get everything done via the protocol, which is nicely written down in 2019. But it's always difficult to follow exactly the steps, and everybody's being focused on that study. So it fades out, I think.
And also how the surgeon approach the patients and what they say and what they believe also impacts the patient's decisions.
Oh, so. Yeah. And not in this study particularly, but I hear that, like, oh no, this herniation is so big, you for sure need to, you can go for an injection, but you need surgery anyway because it's too big. Where the evidence is really saying the bigger the better. So if you have a huge herniated, extruded, sequestrated herniation, you get a lot of inflammation, you get a lot of pain, but mostly those patients do way better on the very tiny ones, or just sitting in a lateral corner, hitting the nerve a bit and make the nerve angry. After a while, they have much less good natural history than the big ones, and it's all it's all written down already. It's not new. Yeah.
It would be interesting if you could see those patients that have, surgery, they are indicated to have surgery, but haven't passed through the surgeon, maybe just through an imaging or some evaluation, just to see if that taking out that bias of the surgeon would change things.
I can't follow you totally. So say that again.
So like if you had patients, for example, that you got an MRI, you see they have like a bulging disc, prolapsed disc, and see them and do all of that before they pass through the surgeon. They are potential candidates. They have the image confirming, but they haven't seen the surgeon, just to see if you remove the bias from the encounter with the surgeon.
Yeah.
Because that's powerful. Like if the surgeon is saying like, you're going to have to do this is big, That's all the patient needs to hear, to be scared. It's like, okay, that's the plan. That's what we're doing. So they already made their minds, versus you having patients that they have the image, they have the diagnosis, and they could, and not having that encounter.
Yeah. Yeah. Although on the other side, we really still have to admit that surgery is as good as conservative care. And if you look in most of the reviews, it's still going a little bit quicker, etc. So we are not doing much better, or I think surgery still wins in a lot of reviews from conservative care. So in that sense, I'm happy with this paper as well, because it shows that we really can do something else. And another thing which we can, maybe if we have time still, yeah, we have, I think. Another thing is that if you look into research on transforaminals or epidurals for herniated discs, they don't have good figures as well. They just, it always ends with, yeah, it will give some pain relief, but for very short term. Where the paper from 2014 and this paper as well shows that if you don't use it as a standalone treatment, so not only doing a transforaminal and then say, okay, we will see where you end up, but follow it up with some good advice and some movements if you can do that or whatever, then you will have this long-term result as well. And I think, for me, it's totally logical because you have this people who really have this inflammation. You can't move them. If I do a side gliding with 1 millimeter and they get this shooting pain down the leg, then I'm lost because I can't move. So what is the thing I can do? Of course, I can explain and give advice and opening up and put them in a certain position that they don't feel that much pain. But I can't start. What I really like to do is giving exercises and self-management. Of course, in advice, that's self-management as well. But then decreasing that inflammation, decreasing the swelling with an epidural is a nice thing to do. And then if you follow up with your exercise, because now you have space again to move, then maybe so the one part is the chemical part, the other one is the mechanical part, which needs to be addressed, I think.
Mm-hmm.
All right.
Yeah. Yeah.
And then there is another thing which is the timing of the transforaminal. In our clinic, we don't have much problem with that because we only see them after they have had a few weeks of conservative care. So mostly people have like subacute or chronic problems. Because if you just had your herniated disc, it's now proven that the epidural injection doesn't make that much difference. And where you could argue that if you start to reduce inflammation in the beginning, you stop the reduction of the herniation. You stop that process because you need that inflammation to get regression of your herniated disc material. So my advice would be, if you can handle your patient putting in a certain position where they feel comfortable, etc., stay away from it for at least 6 to 8 weeks before you send off for a transforaminal, because you need that regression of disc material, and that's done in the inflammation phase. So in inflammation which is there for a few weeks. So I don't think it's a very clever idea to, I have this awful pain for 2 days. Now I send you off and give an injection. And there is a nice the STAR trial in the Netherlands from Bas van der Meulen, who just came out, I think, 2 years ago. He showed that early epidurals are not working at all, not better than doing nothing. So that's an important one as well.
Yeah, that's an interesting point. And I don't know if you had a chance to listen to, but I talked with Mark Laslet about his last paper that he published, talking about the level with the analgesic and the steroid injections to confirm with the analgesic response, if steroid level, and then the corticoid to see the inflammation. So I thought it was very interesting and curious to see how more information and more data coming from that as well.
Yeah, I think Yeah, I congratulated Mark with that paper because that's an interesting one. It's the first study, not the first one, but at least the bigger one who's done that. I had some problems with they use different analgesics like bivouac and lidocaine, which have different time frames. So there are some technical stuff in there. Under CT injections are you can't follow where the contrast medium is going to, so it's not that precise as a fluoroscope one, under X-ray one. So there were different, but I think it's really nice to look into that differences in response. Where I think what is not done yet as well, which is absolute, I can't understand why, is that if you look in all the inclusion criteria for all the transfemoral studies, they only talk about compression of the nerve root on MRI, and you should have at least 4 out of 10 leg pain, which is interesting because 4 out of 10 leg pain. What is that? Is that intermittent or is that constant? Or so that's mostly the inclusion. Mm-hmm. And then they say, yeah, it didn't work or it did work, and then the reviews are going. One says, yeah, it's okay, and the other one says, no, it doesn't have effect. Where I think if you put corticosteroids in a patient, you should do that when there is an inflammatory response. And I think there's coming out more and more evidence that on the nerve root, where the nerve root is, there could be inflammation. I was part of a study which just came out like a month ago, or even not a month, I think a few weeks ago, where we looked into cervical radiculopathy, and we made like PET scans with nuclear material, and showing that people with a neck herniation had inflammation on that nerve root way more than the people who don't have a herniated disc. So you have the pictures that is really inflamed. The thing which came out there, it was not related to the clinical, to the clinics, at least what they had measured. So it was not related to the amount of arm pain, for instance. So you could have a lot of inflammation on the PET scan, but not that much arm pain. And the other way around as well, less inflammation, a lot of arm pain. For the low back, there is an article, and it's only a small article, and it's one article, and you can argue if it's done nicely, but if it didn't look into really the nerve root which was inflamed, but the material around the nerve root which was inflamed, and they had you need constant pain, you need really severe night pain. You need morning stiffness, which takes you an hour to get rid of, and short walking doesn't help you. And that's what they call the inflammation score. And if they look into the tissue, so they took out disc material, then the people who were having those inflammation score 3 out of 4, they really had the highest inflamed herniated disc tissue. So nobody looked at in transfemoral epidural studies, looked at, are those people really inflamed? And the leg pain doesn't say it. And as we saw in the arm pain as well, it doesn't say the amount of leg or arm pain, doesn't say how inflamed it is. It's other issues. So we are now looking back in that cervical study, because I was just sideways on the call, so that I'm on the side. Now we're looking in those criteria, which we know from the lumbar spine, and we're going to see if we can find in the D-base of the patients, if we can find that same set of things, which is what I said, constant pain, night pain. So if it's not inflamed, why would you put corticosteroids on a nerve root? If it's not inflamed, it's not inflamed. It's not going to help you. So if your inclusion criteria is that bad, then it's not strange to see that half of the studies don't work. Mm-hmm. Nobody looked at that up till now. So that's the next study I'm doing, looking at people who have this criteria and how they were doing on transfemoral epidural injections, if they have this inflammation score on a high level.
Mm-hmm. If they would respond better, right? Then
we don't know yet. That's research.
Yeah,
but,
if they would, yes, that's the question.
Could be logical. For me, it sounds very logical, very simple.
So, and based on everything that you just said, who would you recommend to have an injection? Like, so you said that if they can find a good position, wait for a few weeks. So who would fit the criteria, in your opinion, to get an injection that would be more efficient?
So not the people who just had a herniated disc, and of course, or a herniated disc with a radicular syndrome. And of course, if you can't sleep for 2 weeks, you try everything to reduce it. And as we do know, oxycodone and 𝐤𝐴𝐿 doesn't work on neurogenic pain. So there could be an option to do it, because if you can't sleep, you get crazy. But if it's not too high, the pain, and you can find positions which are giving you less pain, or you find something which can help you a bit, and you get some medication, and you can wait a few weeks. I would do that. If I would have a radicular syndrome, I would wait at least 6 weeks before they put an injection in my body. So that's what I would do, because I know for regression of your herniated disc, or for natural history, you need that inflammatory response. That's what we really know from a lot of evidence now. But later on, if you keep that inflammatory response on loading, like long pain afterwards, and this like constant pain, night pain, and this should be severe night pain. So you really need to go out of bed, because otherwise you can't sleep again, or you need to take medication, otherwise you can't sleep again. So it's not, I turn around, I wake up and I sleep further. That's not severe night pain. And this morning stiffness, then those people, they stay in, I don't know why, but they stay in this inflammatory nerve root response. They are really good and you can't find centralization. You can't move them. You can't find the positions which is really helping them in a few days to get rid of that pain, or at least less pain. Then that would be a perfect candidate to do an injection on. Of course, you need an MRI for that, to do that, for safety issues. So that's the other part of the story. It makes it a little bit more costly. And I think in the States, they are way more costly than do it in my country. So that's another thing of it.
Mm-hmm. And wait 6 weeks if you can, right? If you can tolerate that. Yeah.
If you can't tolerate it, so I've seen patients who are they can't even sit. They just walk around in my treatment room, and they are very irritated, and they react very heavily, and they didn't sleep for a week or two. We will inject them. It's just then we will see how it ends. But
And then in your practice, after having the injection on these people that you just described, right, the ones that are recommended, do they usually respond with exercise, MDT after the injection?
Yeah, it's better than in the 2014 and 2025 paper, because there we see patients with a radicular syndrome, but they're not necessarily surgery candidates, right? So I've done I didn't publish that, but I've done a screening from data from 2014 to 2016, looking at how many patients in our clinic were at the end sent to, so they got combined treatment, and then how many were sent to the neurosurgeon, and that was just over 10%. And I had way more patients who really got much better from MDT alone, so a bigger group, but also much better from the injections as well.
Mm-hmm.
Yeah,
that's awesome.
But I think that's logical, because it's a different population. Yeah.
Okay. So much better results with that population.
Yeah.
And once you said about respecting the leg pain, right? Were you talking about just the education that you described, like when you were talking to the patient? Was that something else to the respect to the leg pain?
No, so we talk about that way more specific, as I said, like very precise, like how much do halfway and try to build up again. On those people who don't centralize their pain. So we want them to move. So that's what I start with. So movement is the glue for the nerve, but you shouldn't make it angry. And you don't make it angry if you follow those strict rules. So that's what our gross term is respect your leg pain on that.
Yeah, so just educating them about that.
Yeah, and that's, if I look in my clinic, I see like 10 to 12 radicular syndromes a day, and I think half of them I'm just talking. I do nothing. It's just explaining. Natural history is another one. Your natural history is pretty, so how long do you have pain? Oh, it's 4 weeks now. Oh, it's awful, isn't it? You can't sleep very well. You have this awful leg pain and it's burning the whole day and blah, 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 what it's taught me. But it's 4 weeks. So the good story here is that if you wait another 4 weeks, you have a big chance, namely 80%, that it gets way better. And so that explaining the natural history is so important for patients. And that's what I have that on a diagram on my whiteboard, and I never wipe it out because I use it the whole day. And people really say, like, I'm so happy you explained this. So I call it my breathe out diagram. People start to relax on it. It's really true. I spent like 5 minutes on that every time I see a radicular syndrome, and asking them where they are in their having their maximum leg pain. So when did your maximum leg pain start? Oh, I had back pain for the last year, and then it started to go in my buttock. But the last 5 weeks, I have this maximum leg pain. Then that could be an important education as well. Yeah.
And like on your patient population, we were discussing that before, you also see a lot of other classifications, right? So from these patients that you're seeing in your clinic, some are going to have derangements, and then a lot of them are also going to be classified on the other. So you're going to have to end up educating them as well, since they're not going to be like a simple case of centralizing, right?
Yeah, so normally not. So another paper I published this year was the reliability study, where you can see all those others and also the figures on that. I think at the moment we are having, like, in all the clinics, like 20 to 25% is derangement and the rest is other. So we have a way bigger set of people who are other than what I was having when I was in primary care in a physical therapy clinic. I think we have these studies, we have these surveys in the institute where we see that 75% almost is derangement. In our clinic, it's the other way around. Yeah. So there's a lot of stenosis, a lot of foraminal stenosis, listhesis, 𝐤𝐤𝐥 problems, whatever you can think of, chronic pain. So,
not those nice ones that just centralize and you're good.
Oh, once in a while you have those. Yeah.
I thought that was very interesting. I was like reading our paper as well about the reliability, and saw how you see a lot of people from the other classification. So like as you start talking about your patients, I was just thinking, you're going to have to really educate them on the respecting the leg pain and all that you're mentioning, because a lot of them are not going to centralize, a big portion of them. So you're just going to have to help them and educate them on how to manage that, right?
Yeah, and I have to admit, sometimes I miss that you have a few patients in a row that you can just do some whatever direction of movement and they get better. But on the other side, it's interesting because those people have been everywhere. So that otherwise that's the health system in the Netherlands as well. You never end up in a pain clinic before you had conservative treatment. Mm-hmm. It's too black and white, but it's almost like that. Yeah.
And that paper also, the results are very interesting, right? You had the reliability was really good, including, that was, I think, the first one that included the other classification, right? That was assessing the inter-rater reliability.
Yeah.
You want to just briefly mention that, that study? I know we are been talking for a while, but just quickly.
Yeah, I will be quick. Yeah, so all the reliability studies up till this study were done on derangement, dysfunction, postural, and then other as one group. And I think why that is because most people don't see that many others. So it's difficult to do a reliability study on that. And we see a lot of others. So I thought this is the right centers to do that. And it was COVID time, so we had time. We didn't have that many patients. So that's when I started that. Have to say loudly that it's a vignette study. We used a real patient files. We took out all the things which were referring to a diagnosis. We took out all the management. And then, so paper is nice and quiet. So you don't see the patient. You just can read it and read it again until you start to think, this should be this. So it's the lowest level of reliability, but at least it's a start. And the nice thing is that we had 180 patients in the study, and the people who did the rating they produced 30 patients themselves, and they looked into 150 patients from others. So the nice thing of vignette studies is that you can have those big numbers with way more raters than normally done in reliability studies, where you maybe do with two people in the same room, or one patient on the first hour, and the second hour is another therapist with that same patient. So it's a start. At least it showed that we sort of, if we read files carefully as we use all the normal others in our clinics and operational definitions from that, and at least that gave us a really highly reliable kappa value of 0.83 or 2 on average. So that was a good stop. Yeah. That's
awesome. Okay. Hans, we forgot anything before we wrap up? I know we discussed a lot of different things. Anything that you want to mention that we forgot to discuss?
No. I think it was a long talk, so we should stop. Otherwise, people never listen to it anymore. They're gonna fall asleep. Exactly.
And if people want to learn more about the topic, any recommendations, papers? I know you have your papers. Anything else that you recommend people?
Yeah, another very nice source will be two things. Two things, is that possible still?
Yeah.
Most people are trained in mechanical unresponsive radicular syndrome, MUR, or in the States, MURS. That name has been changed to radicular syndrome without directional preference. The reason for that was unresponsive is a strange term, because I give masterclasses on this. So that's the research I would give. Masterclasses on management of the radicular syndrome and stenosis, by the way. So that's a 2-day masterclass. It's organized by the Institute, and you can follow that. Could be online or face-to-face. And the reason to change a radicular syndrome without directional preference is because in a lot of non-English speaking countries, unresponsive means nothing is really happening, like our no effect result, where most of the radicular syndromes, you can make them very responsive, you can make them worse, you can make them no worse, no better. You can't centralize them. So that's why we changed that name. Right. So yeah, I would love to see a lot of master classes in the States, and I'm doing this year. It's funny. It's busy again. So we have six classes planned. So that's good. And we're busy with one clinic in the States to do. We don't know yet, an online or a face-to-face. I'm not feeling totally safe going to the States because my passport has a stamp of Iran and Russia, and so I think I prefer face-to-face at the moment. Online,
virtual. Yeah.
All right.
And Hans, if people want to learn more about you or your work, where they can find you?
On LinkedIn, that's the only how is that called, social media I use. I have nothing else. I don't have Instagram. I don't have Facebook or whatever. But on LinkedIn, you can find me easily. Yeah.
You don't have Twitter, X? No.
Nothing.
Oh, okay.
I'm an old one.
Well, that was awesome. So thank you so much for coming here. I know it took a while for us to put this together, so I'm really happy and glad that I got you here, and we had a lot to discuss, so I appreciate it.
And I appreciate your work as well, having all these people and talking with them, and hopefully other people can learn from that. So that's great work, and keep that going, Mariana, and really thank you for inviting me.
Awesome. Thank you.
Bye-bye.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day, and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes, along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.